Yeah, I mean, just a little bit about where I come from. I'm a UCT undergraduate. My postgraduate training is a mixture of the UK and the Royal College, a fellow of the Royal College of Anaesthetists, and an M.Med from UCT. And then I spent some time after that taking a special interest in doing a fellowship in neuroanesthesia and neurocritical care. Unfortunately, I spend a lot more time nowadays doing admin and sort of systems and health planning than actually delivering anesthetics. But I'm going to speak to you a little bit about general anesthetics and the effects on wakefulness and memory. And I've really enjoyed the week, and my colleagues have given very different angles on various topics. And lots of them have been talking about all the wonderful things we can do and how things have got better. Ivan took us a little bit down when he spoke about death and dying. And tonight, I think I'm going to sort of dabble a little bit in sort of voodoo and black magic. And I'm hoping that I'm not going to get you too worried, because I'm going to show you a little bit about how little we know about the effects of general anesthetics. So I don't want you to be too worried. I'm going to start off with some data, and I'll try and end off to show that actually it's not as bad as it may look in the middle. So first of all, just some declarations. I'm not an expert on either consciousness or memory, but I'm a practicing specialist anesthesiologist, and I'm curious about two things. What are we doing to our patients when we see them lying there on the operating table? And also, I'm a little bit puzzled by why so few of my colleagues seem that interested in the state that we're producing and what we're doing to their minds. They're far more interested in other things. And at one of the big meetings held every 5 years to discuss mechanisms of anesthetic action from around the world, this is the premier meeting. They managed to assemble this many people. Half of them are basic scientists. So only half of these people are clinical anaesthetists. And given that in the UK there are 11,000 specialist anaesthetists, 55,000 anesthesiologists in the USA, I was the only person from the African continent there, you realize that actually there are not that many of us who are that interested in this. And in the British Journal of Anaesthesia last year, Russell and Wang wrote this: "We do not believe that practicing anaesthetists or their patients are generally concerned about sophisticated models of consciousness. They simply want to know when to deepen or possibly lighten the anesthetic." And I was somewhat reassured by that. In fact, it's actually normal that most of the guys want to know what they should be doing rather than thinking about what's happening in the background. So the roadmap for my presentation tonight, I'm going to look a little bit at the evolution of anesthetic agents and the state of anesthesia that we're producing. And then just compare and contrast sleep, coma, and anesthesia and how they may differ or be similar. And then look a little bit at consciousness, immobility, and memory, those aspects of the state of anesthesia, and how in particular we monitor the sort of level of consciousness or altered consciousness that we're playing with. And then finally end off with some current theories of how the state of general anesthesia is produced. Just a glossary to start with. I'm going to talk quite a lot about the EEG. So this is an electroencephalogram. The classic one would have 19 electrodes and 2 other sort of reference electrodes over the scalp, and you're measuring the electrical activity of the cortex of the brain. A lot of the ones we're using under anesthesia are called processed EEGs, so they're not the raw data, and they're just 2 electrodes placed on either side of the forehead. So it's a lot simpler than the data we're getting out of an EEG that the neurologist would be using. I'll speak quite a lot about the neurological correlate of consciousness. Now, there's a question mark there because we don't know what it is or where it is. It's just wherever, if we could find that, it's the holy grail of neuroscience. If we could find that, we could then start targeting a lot of attention to it and understanding what we're trying to do and how we're doing it. But at the moment, we don't even know what it is or where it is. And then inhalational agents. These, we get them in a bottle like this. We place them in a vaporizer like that. And then through carrier gases, we administer them to patients. And people talk about anesthetic gases. They're actually indeed vapors. And that's what I'll talk quite a lot about them. And then the intravenous agents are the things that you see us have in syringes. We sometimes give them freehand in a syringe. And then we can give them in sophisticated syringe drivers like this. So those are some simple things to start off with. So I said I'd start off with reassuring you. And if anesthesia is a little bit like parachuting, there's not a lot of evidence that it works, and yet everybody wants it. If you had to jump out of an airplane, you'd want the parachute, and it's a bit like that with anesthetics since the 1846 on Morton. So it's not well studied, but we know that every week in the United States, or every day in the United States, 60,000 patients will have procedures under anesthesia. Around the world, 230 million major surgeries are estimated to occur. And we all know many people who've had anesthesia for surgery, and lots of us have had our own anesthetics for our own surgery. So it works and people want it, but if you try and see what's the evidence that you should have it or not have it, there's not a lot out there. If you look at satisfaction from the the state that anesthesia provides, there's not a lot of work either. One Swiss study with 2,300 patients showed that 98.7% of patients felt it was a good or an excellent experience. And the biggest study is the Australian study of 10,800 patients with high satisfaction in almost 97% of patients. So I think most of you would agree if you had to have an operation, you'd want anesthetics, but there's not a lot of literature to back that up. It's just accepted that since Morton's day that it would be better. So how were they developed? They were developed empirically, the general anesthetics. They weren't designer drugs that people decided, I need to create a drug that's going to do this. They basically came across it serendipitously, and it produced the kind of things that they were wanting. Patients lay still, they were comfortable, and they described it as much better than what potentially could have happened to them. There have really been 3 generations as I see it. This is my classification. And Peter Gordon spoke on Monday night about the start with ether and chloroform. And nitrous oxide was around that time. And then by the 1950s, those 2 had disappeared, and halothane and enfluorine were developed. Nitrous remains through all 3 stages. And isoflurane and thiopentone came soon after the 50s. And then at the moment, we're using really isoflurane remains. But sevoflurane and desflurane are the other big vapors that we're using. Nitrous remains a consistent drug, and propofol is probably close to the ideal intravenous drug that we're using. So there's been this sort of stage as it's come along. But what is the state of anesthesia? I think we accept that it's a drug-induced state, and it's characterized by several components. Firstly, there's altered, I've written here unconsciousness, but I'm a little uncomfortable with this, and I think by the end of this presentation you'll probably realize why. And that's why I've put it in italics. And then it's associated with amnesia, so you don't recall what happened under the state of general anesthesia in the vast majority of cases. We also produce a state of analgesia, and patients lie still. Before anesthetics, patients would be moving all over and people have to hold them down while they had their surgery and they were screaming. So this is a desirable part of the state of anesthesia. And when we teach anesthetics to undergraduates, we use the so-called triad of anesthesia. And there are 3 components to this. And hypnosis is here at the top, the sort of altering of the consciousness. But these 2 components I'll start off with are analgesia. So almost every general anesthetic will have hypnosis and analgesia. And in certain cases, we will paralyze patients using neuromuscular blockers as well. And the reasons that we paralyze people is if they're at risk of aspiration of their gastric contents for emergency surgery, or if they have hiatus hernia, we then have to paralyze them to put an endotracheal tube, which Ivan showed you in the ICU course, into their trachea to protect their lungs. We paralyze them when the surgeons need access into the chest cavity or into the abdomen, and they don't want the muscle tone stopping their hands getting where they need to be. And then we also paralyze patients when there's very delicate surgery. So we're doing neurosurgery, and they may have an instrument right through the brain or operating under the microscope, and we cannot have any movement. And so patients have to be absolutely still for that type of surgery, and we paralyze patients. Those are the sort of 3 big categories that we land up paralyzing patients for. And when we paralyze patients, we understand the receptors that those drugs are working at. We understand how they bind to those receptors. We understand what makes them work longer and shorter. They're designed drugs that actually fall apart without being broken down by the liver. So in liver failure, you can use them. So these are designer drugs that you're using at that level. And we understand how to reverse those drugs, and we have drugs to reverse them. So we're in a lot of control at that level. At a designer drug, we understand the process. The analgesic component, apart from paracetamol, which we really don't understand its workings very well, and remains a good drug, as Owen said last night, we understand where the opiate receptors are. We understand how the drugs work there, the same as the non-steroidal anti-inflammatory drugs, the Brufen group. These are drugs, they design drugs to work at that receptor. We understand that, and we understand why things happen and why complications happen. But this group up here, the hypnotic agents, we really have very little understanding of where they're working, how they're working, and yet that is the main part of the state of anesthesia, of general anesthesia that we're producing. And then the surgeons don't want patients to move. And so we can use relaxants to do that. So neuromuscular blockers, if you use that, the patients won't move. But normally a combination of hypnosis, the hypnotic agent, and the analgesic agent, the painkiller, will result in the patient lying still. A large component coming from the hypnotic agent itself. So if we compare sleep, coma, and anesthesia, sleep is a state of decreased arousal. it's generated actively. So when you go to sleep, the ventrolateral preoptic nucleus is thought to initiate the process of sleep. So it actually makes you go to sleep. You don't sort of just drift down slowly. You actually get to a stage where you actually have activation and the initiation of sleep. And then sleep cycles between REM and non-REM sleep. So you have 3 stages of non-REM sleep, and then you have some REM sleep when you're virtually paralyzed in your body, and you have your dreams, and then you go back into non-REM. And so you do that through the whole night. But you remain arousable if somebody comes into the room, and it depends on the environment. If it's noisy, you may wake up. If it's very quiet, you might sleep very deeply. And then it's largely protective of physiology. If you get thirsty in the night, you'll get up and have a drink. If you never get pressure sores by sleeping in your own bed when you're naturally asleep, because you'll look after your body. You would roll over if it became uncomfortable. So that all remains intact. And then there's the dream state, which occurs in the REM sleep. And it's very close, potentially, to the conscious state. And I'll speak a little bit more about the dream state in a moment. Anesthesia, it's a state of altered consciousness. So we change your consciousness, and then there's a loss of reflexes, which doesn't occur in sleep. So progressively, as you get deeper in anesthesia, you lose the reflexes. You lose lash reflex, corneal reflex, the reflexes at the back of your throat, your gag reflex. Everything eventually goes as you get deeper and deeper under anesthesia. You lose thermoregulation, so you just start losing heat, and we have to keep patients warm under anesthesia. And there's a progressive depth. You don't have the cycling that you have with sleep. And there are different clinical stages, but we can take you to a stage and then keep you and hold you at that stage. And it's a relatively stable physiological condition. Coma, I think, is quite different from those two. It's a state of profound unresponsiveness. It's usually a result of a brain injury, either traumatic or an infarct, like a stroke or hemorrhagic insult, or you can have metabolic causes of coma. But it's not predictably reversible. You can't wake it like sleep or reverse it like anesthesia. And you normally can't rouse these patients even with vigorous stimulation. And they're unable to provide even the most basic care for themselves and reflexes. And these are patients that get pressure ulcers. They get dehydrated if they don't get given fluids. And I think at this point it's important to say you often hear about medically induced coma. When you talk about that, you're actually talking about anesthetic. That's what an anesthetic is. It's actually quite different to the coma because you've got an injury to your brain. That's a very different state. So if you take sleep and compare it to anesthesia in a little more detail, because I think coma is a different thing. Somebody spoke earlier in the week about comparing anesthesia to an aircraft taking off, flying, and then landing. And anesthesia and sleep share those kind of things, an onset stage, a maintenance, and an offset. And if you take any one of those stages and look in a bit more detail, they share various things. So if you look at anesthesia and sleep in the maintenance phase, they both have altered respiration. You hear that in your partner who's sleeping. You can hear they change their breathing is not the same as when they awake, and under anesthesia is the same. There's a possibility of dreaming. In anesthesia, it's not so much rated in adults, but in children they seem to dream. There's amnesia for that period that you're in that state. There's altered consciousness, and there's a loss of muscle tone. So they share those things. But there are also some big differences. With sleep, you can fail to go to sleep or to stay asleep. With anesthesia, if we've got enough drug, we can keep you in that state for days and potentially weeks. So there's no failure of it. And then sleep is altered by environmental factors. Whereas anesthesia, it doesn't matter. If the orthopedic surgeons are whacking things into your leg, you don't wake up because of that. And then the other things that are different is that the sleep oscillates between REM and non-REM, whereas anesthetic depth is held at a constant rate. And then the duration of sleep depends on whether you were tired before you went to sleep and what your normal sleep-awake patterns are. Whereas with anesthesia, it doesn't matter how you arrive. We can induce the state of anesthesia whether you've just woken up from a sleep or whether you haven't had sleep for 10 days. It's completely independent of those. So what is the state of anesthesia? Well, anesthesia really came about, and the definitions started being made shortly after the use of ether. And really what happened was there's an ability to eliminate pain, because that's what they were worried about, and that the patients lay still. So it was that combination. But what ether and chloroform required was essentially for patients to enter a state of almost unconsciousness before they got the analgesic effects that people were looking for. And because of that, the desirable state of anesthesia for surgery included the fact that patients were in an unconscious state. And we know that that's not true, because many, many patients have major surgery with a spinal anesthetic or an epidural anesthetic or a regional block. They're absolutely wide awake. They're having major surgery. And you don't need to have an altered state of consciousness. What you want to be is just so that you don't feel pain and unpleasantness. So it's not a requirement that you be unconscious. It was just that the early anesthetics required that to make surgery bearable. In 1900, Overton, and I like this because he added to this definition really by saying that it was an insensitive to surgical intervention state. So he's not talking about consciousness, but I like the fact that he added that patients should not be harmed during that state. And some of the more modern definitions are including that. Now, if you look at what people around the world who are specialists in this field are describing the state as, the American Board of Anesthesiologists, they train and certify specialist anesthesiologists in the United States. Their definition is the practice of medicine providing insensibility to pain during surgical, obstetric, therapeutic, and diagnostic procedures. No mention of consciousness in their definition. But the ASA, the American Society of Anesthesiologists, their first line is that the patient is unconscious. So even in the United States, the two big groups seem to have a different wording in their definitions. In a review in 2010 in the NEJM, the New England Journal of Medicine, is that and by some prominent minds in the field, they included that it was definitely unconsciousness, and they tried to target where it potentially was happening. But importantly, and I think we'll come to this when I talk about the potency of our agents and how we measure that, they said it's contributed to by altering the spinal cord transmission. So a lot of the effects of the general anesthetics that we see and we are looking for are actually because they're blocking the spinal cord. At that big mechanisms meeting in 2010, there's a lot of debate in the first day about what actually the state of anesthesia is, because you can't study it and agree that this model works and shows this unless you actually know what you're trying to describe. And what they said, well, what they concluded at that meeting is that it's a general anesthesia is a pharmacological intervention used to prevent psychological and somatic adverse effects of surgical trauma, and also to create convenient conditions for surgery. No mention of consciousness in the sort of the state-of-the-art definition of what general anesthetics are. So I like this homegrown one. This comes in the 2008 World Congress in Cape Town. Bishop Tutu had recently had his prostate operated on, and he opened the Congress, and this is what he had to say about anesthesia. And I love it. Somebody asked about the other day. So the question is, and you may be getting a sense of where I'm going, is anesthesia oblivion on this left-hand side? We definitely don't want it to be here, but where are we? Are we more in the middle, or are we going to be somewhere here? And Tony Houdet from Wisconsin, who's one of the big players in this field, he's pretty sure that it's just some form of altered consciousness, which is the term that I'm certainly using in my life. And if the hypothesis is that it's just altered consciousness, then we want to know, where is this altering happening, at what kind of level? And we don't have any idea. It could be a few critical molecules somewhere. It could be one or two synapses where nerves come together, or it could be a clumping of whole nerves or neurons themselves. We don't know. It could just be a few interactions between a couple of nerves, or it could be a particular region in the brain or the central nervous system. Or it could be that the whole brain needs to work through a complex circuitry, and that if that circuitry falls apart, that things don't work. So we actually don't know whether it's a tiny critical area or a big picture kind of thing that we're looking at. And as I said, the holy grail is this neurological correlate of consciousness. If we understood that, we knew where it was, we could then really start hunting down what we're trying to find about what is consciousness and how we can alter it. So if we accept that the general anesthesia needs to include analgesia, undoubtedly you need to have your pain relief sorted out. That's something. We then have to think about, if we're going to alter your consciousness, make you lie still, and have no unpleasant memories of what is happening, then what might we be looking at? And I'll try and look into these separately. So what is consciousness? Tony Houdet, once again, I mean, for me, consciousness would be an awareness of if I was aware of what is happening around me, and I was aware of myself and how I was. For me, that's sort of the most basic thing. But then he adds to that by saying it's a subjective experience. Its problem is that it's not directly measurable. If somebody is lying on this table with their eyes closed, absolutely still, you have no idea whether they're conscious or not. And if you talk to them and they don't respond to you, you still have no idea. If you poke them and they move, you still don't know whether they're conscious. They just had some motor response to that. So we rely on measuring consciousness by the response in response to us asking a question or doing something, and seeing the behavioral responses is how we work out if somebody's conscious. It's a very difficult thing to measure. And that's why things like people who have central pontine strokes and who have no motor ability at all are completely conscious, and yet they have no ability, apart from often just blinking an eye, to communicate. And it's very difficult if people don't respond to work out whether they're conscious or not. So it's a very difficult thing to do. But certainly consciousness probably includes all these sort of higher functions that we would think about: sensations, feelings, perceptions, emotions, thoughts, desires, some inner speech and thinking, reflection. But it's certainly not mobility, because you can be completely still or have a central pontine stroke and be completely conscious. It's not memory, because we know patients with Alzheimer's disease, they have dreadful memory, but when you talk to them, you can have a discussion about the cup of tea, and that's fine, but they have no recall of that, but they're conscious when you're talking to them about their cup of tea. And it's not sensory motor processing. So we see this, and this is it's a concern about the whole state of sleepwalking, because sleepwalking is a fascinating state. If you ever grab somebody who's sleepwalking, they have a sense of purpose. They're going somewhere. They're going to do something. They're often mumbling. But if you try and wake them up, you really have to work hard to get them awake. And if you do manage to wake them up, they don't know where they are, what they're doing. Whereas if you wake somebody from a dream, they can often tell you, I was dreaming about this or that. So sleepwalking is a very different state. So it's not mobility or immobility or the memory. So it's a difficult state to try and work out. And then if you think about that and all those higher functions we were talking about, then you can start saying, well, is a rat conscious? And I think probably most of us would say rats are probably conscious. And then the cockroach that I walked into a room the other night and was sitting on top of the door as I turned the light on and looking at me, and it was probably wondering, the lights come on, it's supposed to be dark, there's movement. Surely that thing was conscious? I don't know, maybe it was. But then where below the cockroaches do you lose all these definitions of awareness and things? So it's an interesting idea. I don't know the answer, and as far as I'm aware, we don't have a fantastic idea of exactly what we're talking about. Now, in the field we work in, it's very difficult because we use all sorts of different terms for all sorts of different things, and there is just no agreement if you go to practicing anaesthetists. So we're using terms like awareness, wakefulness, consciousness interchangeably, and it makes it extremely difficult in the field that we work in. And as I said, there's some big difficulties. Sleepwalking, the vegetative state is an interesting state. So often, Ivan spoke about you don't want to be in a vegetative state. And people would agree that mostly you have no sense of what's happening around you, except if you look at the EEG readings of many patients in the vegetative state, that there's different daytime and nighttime patterns that you're seeing. So they have a diurnal change. And so if they're sensing day and night, where does consciousness start in those kind of things? And then dreams are fascinating. And I'm going to speak a little bit more about those in a moment, about how close to consciousness they can be. So it's very difficult if you're unresponsive to work out whether you're unconscious. And that's the problem with anesthetics, is that we render patients immobile, and then we're trying to work out, well, they just look like they're unconscious, but in fact, what are they like? So with low doses of anesthetics, patients become amnesic, and they just gently drift off, they lose time distortion, and they become a bit sleepy. And then at higher doses, they stop responding. And because of how anesthetics were developed 160 years ago, we think they're unconscious because they're not responding. And that's just sort of become urban legend about how anesthetics work. And that may not be entirely true. The other difficulty about immobility and consciousness is the whole state of dreaming, which I said I would come to. So in dreams, you can have those vivid feelings, fear, emotions. You can wake up absolutely terrified with your heart beating. That has got to be so close to consciousness. And somebody wakes you up, or you wake up and you can remember, I was dreaming about this. So you have memory of what you were thinking about then. And often it's related to things that are happening in your daily life. And so there's a feeling that after the state that we're in now, dreams may be the next state that we're closest to consciousness. That's the next closest state to consciousness, because it meets so many of the criteria of consciousness. And then dissociative anesthetics like ketamine. Some of you may have heard of ketamine. And now ketamine removes your ability, your volition to initiate movement. So patients often lie there, but they describe extremely unpleasant sensations, and we can see them looking around a room in recovery from anesthetics. They're almost trapped in their body, and they'll be looking at the roof, seeing, and afterwards they'll tell you they were seeing insects, or they feel things under their skin. So they're aware of where they are, they're aware of the room, but they're adding sort of a psychotic thing, a layer on top of that. And so it's very difficult. What is the state of consciousness? These people are lying there, and they're imagining all these things, adding it in, but they're aware of the surroundings, but it's just altered. So I think just to throw the cat amongst the pigeons, I'm quite fortunate to have this from Mike Tunstall, who did the early work on isolated forearm technique. And if you just watch the patient's hand in particular.
Mrs. Nejthardt, open and shut your fingers. Open and shut your fingers, that's right. Now squeeze my hand tight. Squeeze my hand tight. Just hold it tight, that's right.
This mother is anaesthetized and the trachea intubated in preparation for delivery by caesarean section. She is able to indicate her wakefulness because her right arm is isolated by a pneumatic tourniquet which was applied before the muscle relaxant was given.
Give my hand one tight squeeze and hold it there. All right, if you're uncomfortable, open and shut your fingers. Well, you'll be more and more asleep very soon now.
Okay, so I don't want you to be too alarmed about that. So that's called the isolated forearm technique, where you blow a tourniquet up above arterial pressure so you don't get blood into the arm before you give a muscle relaxant. So you have it a way of being able to communicate with the patient. And Mike Tunstall, he pioneered that work, and it remains probably the gold standard of measuring whether there's any responsiveness from a patient. And so in last year, it was one of his disciples, Ian Russell, put together all the published work looking at the isolated forearm technique, looking at 1,300 patients. And what they found in this group of patients in multiple studies is that the 2% patients had explicit recall afterwards. And that's about 10 times higher than we would expect in the general population. And there are good reasons for this, because these patients were primed beforehand, and they were pestering the patients during the procedure to basically see what state they were in, and then afterwards they were following up. So there's good reasons that potentially this was happening. And they then graded the responses that the patients had. And I'll just show you what they are. So 49% of the patients had absolutely no response, which is what you want, them to have a negative response to the isolated forearm technique under general anesthesia. And then about 11% each had either reflex grip, which is the most primitive one, which you see in tiny neonates, or otherwise that in response to a noxious stimulus, the response 2 there. But 32% of them, when they were told, squeeze my hand twice or once, responded. Remember, only 2% of these patients afterwards had any recall of this. So fully 32% directly responded to a command, and a further 12% were able to answer a choice. So they said, if you have pain, squeeze once. If you don't have pain, squeeze twice. Or they were able to communicate, so at a higher level of functioning. And yet afterwards, they have no recall. So that's why we're calling this state a state of wakefulness. It's not unconsciousness. You don't have this in your explicit memory or afterwards, and it's an altered state. And I think it's an interesting state, and people are not thinking enough. They often think that they're completely unconscious, and it's not. So what about anesthesia and immobilization? Peter Gordon, who's here tonight, showed Queen Victoria getting chloroform by John Snow. And he, as long ago as the 1850s, said immobility is an important clinical goal and equally important experimental endpoint. But he said anesthesia keeps patients still who would otherwise not be. And that immobility is absolutely critical to the work we do. And people often think it's just the unconsciousness, but actually patients must be comfortable and must lie still are probably the primary things that we're wanting. So how do we monitor the adequacy of the depth of anesthesia, given that the isolated forearm technique might be possibly the best way of making sure that people are actually quite deeply asleep? It's very seldom done. But what we use is 3 other techniques. We use the minimum alveolar concentration, the physiological indicators, and then the processed EEG. So the minimum alveolar concentration is just the concentration at the alveolus in the lung, which is the same as the last bit of your breath out, at which 50% of patients won't move in response to a standard surgical stimulus on the abdomen. So it just tells you that they won't move. It's not measuring consciousness. And what we know is that vast numbers of patients would be completely unaware if you're using that as an indicator of your adequacy of anesthetic depth. But what you're measuring here is you're measuring a spinal cord reflex. You're not measuring what's happening in the head. All you're measuring is a pain coming into the spinal cord via a nerve, linking up with a motor nerve, which causes you to withdraw from that pain. And that's what you're measuring. And yet there's quite a good correlation with the hypnotic state and memory, which patients don't have afterwards. So we're using that, and that is our primary indicator of an adequacy of depth of anesthesia. Breath by breath, we are measuring that end-tidal anesthetic concentration. And if you look at it here, you might be a little bit worried by that. But this line here is the response. This is for halothane, one of the older agents, the concentration. And this is the place where 50% of people don't respond to surgical stimulus. Now, this is the MAC awake, which is a lower concentration where patients have actually drifted off. The MAC with spontaneous recall is to the left of this. You probably need 3 times as much drug to stop you making a motor response to surgery as to stopping you having any recall of that. So there's quite a wide safety margin in terms of the MAC value that we measure, which is the response to surgery. We're very lucky in that the MAC value, if you look at this curve, from no patients for no effect to 100% effect, what you can see here is a very narrow range of anesthetic concentration. So it's a very useful marker for us to use to measure, to target anesthetic concentrations to. We're quite lucky because this is a MAC bar, which is when you completely obliterate any autonomic, any heart rate or blood pressure response to surgery or to any intervention that's happening. And if you look at this curve, it's a much slower curve. And if we wanted to block all patients so that 100% were blocked, we'd have to give that concentration. But a large chunk of patients actually need only this much. And we'd have to be overdosing a huge number of patients to make sure that they had no response. We're quite lucky that the MAC value that we're targeting is actually a very, very steep line. And we can target that value and know that almost the whole population is covered by that. And then we're measuring this breath by breath. We're measuring end-tidal anesthetic concentration. We know what's going in of isoflurane, what's coming out, and we know that the MAC of isoflurane is 1.1. Many of our machines will actually give us a MAC value here. So we can see that breath by breath. We also use a lot of clinical monitoring. So in a large part of the world, you wouldn't have anesthetic agent monitoring, and they would just use basic monitoring, looking at heart rate, blood pressure, and the breathing pattern is quite a good thing in patients that are breathing spontaneously. And so we're just looking at things like the heart rate, which actually on the ECG above here, blood pressure, and this breathing pattern where we're seeing the CO2 trace come out here. We also, in patients that aren't paralyzed, we have another fantastic physiological monitor, and that's the patient's foot. Because if you're not paralyzed, you will move in response to surgery way away from where you would start remembering it. And that's a very useful thing, that when patients move, that you know that you should deepen anesthesia. And that's why you probably, patients who are paralyzed in the big recent study in the United Kingdom, and the national study over a year, you have 17 times more likely to have some awareness if you had muscle relaxants in your anesthetic as if you didn't. So if you didn't have muscle relaxants, you had an incidence of 1 in 136,000 of recall afterwards, which is very low. And then the more sophisticated one that people have been pushing, because it'd be lovely to have a fantastic monitor of consciousness, but we just don't know what we should be monitoring, is the EEG. And this is the processed EEG that we look at under anesthesia. And these are the kind of changes that we see. This is when patients are just going to sleep. You see it's basically the baseline is very flat, and there's a lot of high frequency, small amplitude waves. They're not very high. And as you start getting deeper, the waves start becoming slower, and the amplitude starts increasing. You can see these are much higher than there, and also these waves are much slower than those. And then eventually we start seeing these, we call these sleep spindles, and these big slow waves we start seeing through here are called delta waves. And those are indicative of the kind of stage of surgical anesthesia. So we know what we should be looking for. And then when you probably had too much, this is the state when the ECG is almost isoelectric, and we have these bursts coming too, and we call that burst suppression. So there are lots of monitors that have been developed, or at least 4 or 5 that have been developed to try and measure what we're seeing in the EEG. And really what they're looking at is the development of these delta waves coming through here. So in this wave, you potentially can see there's a big wave, and then there are lots of small waves superimposed. If we do a Fourier transformation of that, so basically we're just looking to see what waves make up this series of waves. What are the component waves? We can see there's a slow frequency wave here. This is the frequency on the x-axis, but it's got a big amplitude. And then there's some higher frequency waves with much smaller amplitude. And then using a Shannon transform, they kind of predict the uncertainty in the system. And the more certainty in the system, the deeper the state of anesthesia. And monitors have been developed to look at that. And so that's what we're seeing here. This is a very certain wave here. Wherever you are, if you knew that you were going up here, you know where it would turn at the top, and that's a very predictable waveform. And if you do a Fourier transformation, you see there's a single frequency with a high amplitude, and it has an unpredictability or an entropy value of 0. And then if you look at these two here on the bottom, I'm hoping you can maybe see that there's a big slow wave coming through this one that doesn't exist here. So this has lots of high frequency waves of sort of medium amplitude, but here there seems to be something bigger going through it. And when you look at these, there's the big slow wave, and then lots of faster, lower amplitude waves, which don't exist here. The entropy value here, the predictability here is about 60%, and here it's completely 100%, well, here it's 60% unpredictable, and they're completely unpredictable. So this is a stage of deeper anesthesia than this. This is close to when you're awake, And this is when you're asleep. We never see this, but this would sort of be the perfectly asleep way. And monitors are developed on this. And then they looked at how those waves move in relation to, as you slow the waves down, do some waves catch up with others? And so that relationship between waves is important. And that's resulted in what's called the bispectral index, the BIS monitor. It's used extensively around the world. It's by far the most popular depth of anesthesia monitor. But there's significant concerns about it. It has a proprietary algorithm. We don't understand exactly how it works. They won't release the software inside it. And then when we add two particular drugs they call NMDA antagonists, there's ketamine, which I spoke about, and nitrous oxide, the old gas that we use, is that when those drugs act somewhat differently to the other general anesthetics. And when you have a state of anesthesia and you add another agent, you're actually in a deeper state of anesthesia than you were before that. But this monitor, if you add those agents to whatever the state of anesthesia is, you actually wake up according to them. And it just doesn't make sense. So there are lots of things about this monitor that we don't understand. This is data from right at the end of last year, which is fascinating and is going to be very worrying for the people who believe that the BIS monitor tells them what happens. There's a group of 10 anaesthetists in Australia, and they're from Cairns, so that might explain why they did what they did. But they took it upon each other to paralyze themselves with a short-acting muscle relaxant and a long-acting muscle relaxant 2 days apart. And then their friends ventilated them with a mask whilst they were completely paralyzed with the isolated forearm technique that we explained. And then they did tests of memory and of higher functioning under this state. And what it turns out is that they were completely awake. Their memory was fantastic. Their cognitive functioning was fantastic. Yet the BIS monitor dropped from 92, which is kind of what you expect in a awake patient, shortly afterwards to a reading of 88, and then after 4 minutes, almost reliably plummeted to 52, suggesting this is a state of deep anesthesia. So this is a trace on the BIS monitor of showing what's happening, and yet they were completely awake at that point, and they were able to communicate with their colleagues, and afterwards they passed their tests of cognition. And so I really think that these kind of monitors, they're measuring the cortical stuff, and it's not really what we're wanting to know. So what else do we want to know about? We want to know about memory and anesthesia. And so memory is short-term and long-term. And short-term is that kind of working memory that you're doing. You remember, oh yeah, I've put 3 cups of flour in, and now I must get that. And that's the kind of, and you don't remember the next day what the recipe contained. And that's your short-term working memory. When you put stuff into longer-term memory, you're then start seeing conformational changes. And you can see changes in the memory areas of the brain, particularly related to increased connections between nerves. And then they can measure increases in certain genes, like the CFOS gene, and deposition of proteins happens around those synapses in the memory areas. And there's a strong feeling that the long-term memory is being built up by these protein changes that you can see. And if you use drugs that block memory, you can block those effects. Then later on, you have to go and retrieve those memories. And nobody can explain at the moment how you can retrieve memories from these protein changes or these potential increased links. It's just so hard to believe, and nobody is able. We can see these changes, but what's happening we don't actually know. If you look at the effects of anesthetics, they actually block those effects, and they stop you developing at high concentrations those long-term memory changes. And that's why you get blocked during the period of anesthesia. You block the neuroplasticity, the protein and increased bonding that happens between nerves. So I saw this City Golf the other day when I was thinking about this talk. I was driving up the road and I saw, it wasn't this one, but I saw a green City Golf. And I thought, Jenna Piercy, she's a colleague of mine. She used to, a long time ago, drive a green City Golf. I hadn't seen a green City Golf for probably 10 years. I hadn't thought of Jenna's City Golf probably for 15 years. And yet somehow out of my brain, I was able to haul out the green City Golf and Jenna. And it's just hard to believe that out of some protein, I managed to just snatch that memory. And I think if you're 80 in the audience tonight, then your 21st birthday was in 1956. And it may have been a party like this, and you may not have thought about it for 10 years. And if you do think about your 21st birthday, you know, you're also sucking it out of some protein. I find that extremely hard to believe. When you speak to, I've spoken to some of the people doing research in this area. I think that what we're seeing is that we're seeing whatever's happening there, you're seeing a change in proteins. But that's probably not the reason that we're able to store things and pull them out. It's probably something else, and the proteins are just a marker of that, much like the wind is just a marker of a change in pressure between 2 different areas of air. And so who knows how you're storing that memory, and we really don't know. I mean, it's fascinating to think all that you have in all those memories you have in your brain that you haven't thought of using or accessing for 10 years. And yet if somebody prompts you, you can haul it out. And more importantly, if somebody says, remember we met that person there, and you can't remember, and then they said, remember that party, so-and-so was there, and then slowly you're able to pluck it out. The memory is an amazing thing, and I just think we have so much to learn about it. So what about memory and anesthesia? So we need to just move on. Is that there's explicit memory, which is that you can remember the conscious memory. Jenna and Drover Green City Golf. So that's an example of explicit memory. And it's for facts and events, and we think people have good memories and they're intelligent. And the important areas for this are the hippocampus and the medial temporal lobe, and we know that. But I think the more interesting thing is probably the implicit memory, that in your subconscious. And this is inaccessible to the conscious state. If somebody asks you, how do you tie a shoelace? You know how to tie a shoelace, but to describe it, give your fingers a shoelace and a shoe, and you can do that. You learned that. Once you learned how to do this and do that, but it's there. It exists. And there are lots of things in our habits and our behaviors that are part of us, that influence past experience, that influence how you do things. It's just in your subconscious. And this is an area where people are starting to think about what's the effects of anesthesia and surgery, because these things, we're very worried about people who are wide awake in the anesthetics. But what we must be more worried about potentially is all the people who had anesthetics who are unaware that they are carrying around any subconscious or implicit memory about that event. And that may affect everything in their life. When they drive past the hospital, they might not like taking the children to school if it goes past the hospital. That influences their relation with their kids. We don't know that, and they're starting to think we need to be looking at this area rather than just the explicit memory. And this implicit memory is stored in a different area. It's more in the posterior part of the brain, in the cerebellum, in the midbrain, and in the amygdala, which is a bit more towards the central part. So what about anesthetics and memory? So in low doses, short-term memory remains intact. So if you can, in very low doses of all the general anesthetics agents, patients are able to do simple tasks. They're a bit relaxed, maybe a bit sleepy, but they can still do things and they can have short-term memory. And lots of our drugs, like the benzodiazepines, we use for the unpleasant procedures like gastroscopes. And this is the group of drugs that the date rape drugs belong to, the benzodiazepines. They alter memory, and you can be seemingly completely lucid and not under the influence of drugs whatsoever, and yet afterwards you have no memory for that effect at all. People who see gastroscopies are dreadful procedures to have, but most people who have them are quite happy about it because they've had a benzodiazepine and they have no recall what happened in that gastroscopy room. And so it's very difficult to work out that patients are, or if you have small doses of these things, they're knocking your memory and yet you seem to be completely conscious. And interestingly, that then so you can have short-term memory, but your long-term memory for that time is completely gone. And I know somebody who had a gastroscopy at Christian Barnard Hospital in town, lives in Greenpoint, got home somehow, nobody knows how he got home, but somewhere along the way he went into an art gallery and bought a work of art for tens of thousands of rands that he had no idea about. It was delivered a few weeks later. It was with his credit card. And it was exactly the kind of art that he likes. He buys art, and it's exactly what he likes. So he almost certainly bought that, but he has no recollection. He got home in that state under the influence of benzodiazepines. His memory was completely gone. He was behaving like he would normally behave, except he doesn't remember it whatsoever. So it's an interesting state. And then at higher doses, you start losing short-term memory. So you don't have the memory to go and to do multiple tasks. It shortens into sort of literally down to 5 seconds, 3 seconds of working memory, and then you become unconscious. Okay. And the interesting thing about general anesthetics is that we remove a lot of the memory is gone, and yet your long-term memory stays there. So it's quite an interesting thing to think about, that we can take away all your short-term memory and the long-term memory for that period, but your previous memories, they remain intact largely. So is there a difference between memory and consciousness? And I think we've kind of come there with the story about the art collector. But is that memory and consciousness are not the same thing. You can be completely conscious without memory. And the benzodiazepines, which midazolam is the archetypal example, is a good example of that. But the general anesthetics have an interesting effect. Because if you look at general anesthetics, I'm going to move to the left-hand side here. If you look at 0.2 Mach, so Mach is a way of comparing the potency of agents. So this is the same potency of each of these agents at 0.2 Mach. And you can see at 0.2 Mach is that 75% almost of the halothane patients will have recall of what is happening under a 20% dose of the anesthetic agent. But the other ones, very few of the patients are going to have any recall. If you go down to 5% of a Mach, 0.05 Mach, Isoflurane, sevoflurane, and halothane, almost 100% of patients will remember what was happening under that low concentration. But if you look at desflurane and nitrous oxide, only 75%. 25% of patients will not have memory return at all. This is the same anesthetic concentration, but the effects on memory are completely different. These drugs that we use to produce a state of anesthesia that looks so similar are actually working in very different ways. So what is the incidence of awareness? The awareness associated with general anesthesia is the current term that we're using for this, and it depends on how you measure it. If you go to people afterwards, to every patient, like some of the big studies have gone and said, what is the last thing you remember? What is the first thing you remember afterwards? Did you have any dreams? Did you have any bad dreams? Did you have any bad experiences? So they sort of progressively get more invasive with their questioning. The incidence is about 1 in 10,000 if you approach patients and ask them. If you wait for patients to say, I think I was aware during that anesthetic, the incidence is 10 times less. So it seems that if you go and prompt people, that you actually bring out what might not come out otherwise. So you're actually going to delve into it. And then it's interesting, it depends how long afterwards you go and ask them. So there's an apparent increase in the incidence of awareness in the last few decades. And that's because the early work was going to the patients 24 hours after the anesthetic and asking them if they were aware. And we now know that actually by day 3 to 5, that's when your patients start reporting that they remember what happened in the anesthetic and the operation. And so now people are doing it at 7 days, and you're picking up a much higher incidence because you're measuring it at a different time. So 24 hours, it's not a very good time to measure. So the current incidence, if you look at the Bryce questionnaire, is 17 per 10,000. In the big National Audit Project 5 in the UK, that was a self-reporting, so it relied on patients coming forward spontaneously, 0.5 per 10,000. So 1 patient in every 20,000. But as I said, in that group of patients, 1 in 8,000 if you got a neuromuscular blocker, 1 in 136,000 if you weren't paralyzed and you could use your foot or something else to tell the anesthetist you're awake. So just a few interesting ideas. Jamie Slay is a Zimbabwean who's now working in New Zealand, and he's quite involved in this area. And he wrote an editorial that perhaps your patient isn't a submarine. So we often talk about depth of anesthesia and patients getting deeper, much like a submariner, and you're getting deeper down the darkness and losing the light, and then we reverse it, and patients lighten, as we call it. So we use these terms, much like a submarine. And he pointed out that we need to stop thinking like that. We need to much more think of what we're targeting. What do we want to remove? And we need to think of patients as switchboards, he said. So we need to think. We need to turn off the consciousness thing. We need to turn off the pain things. We need to turn off the autonomic response. And so we need to change how we think. We need to think, what do I want the patient to do? This patient doesn't need to have unconsciousness. They just need to be comfortable and lie still. And maybe that's what you need to do. The other interesting thing that's coming out is that this state of anesthesia, you might think that you just wash stuff in, and then as it washes out, you just return back to where you were. And it doesn't seem like it's that at all. There are 2 interesting bits of research showing that. Firstly is from a group of patients with narcolepsy. They're an unfortunate group of patients who have low levels of orexins or hypocretins. It's an endogenous hormone that keeps you awake. And we all have that. And if you don't, you have lots of daytime somnolence, and those people struggle through life. Those people, if you give them an anesthetic, they are exquisitely sensitive to recovering from that. They take hours to recover when they should have taken minutes to recover. So tiny, tiny remains of the anesthetic agent keep them fast asleep or anesthetized. And yet, if you want to induce anesthesia, you need to use the same doses we would all require. So it suggests that what you require to induce anesthesia is different to returning from that state. And then if you look at individual drugs, this is the dose-response curve for induction for one of the vapors, and you need more of it to induce anesthesia than you do to recover. So you have this hysteresis curve where induction and reversal are different. They're following different curves. And so it may be very different processes. It's cute to think that maybe it's just the drug leaving your body or being metabolized and you just wake up, but it doesn't seem to be like that at all. So the historical hypotheses explaining how these anesthetics work started with some interesting ones. May and Overton individually came up with the same idea in around 1900, is that they basically worked out that there was a logarithmic relationship between the MAC value, which is degree of potency of different inhalational agents, and their solubility in olive oil. And so they thought, well, maybe that means that these drugs are acting at some lipid-soluble site, and that's why we're seeing this relationship. And for a long time, that seemed to be the answer. But now we know that seems to just be a coincidence. In the 1970s, some interesting work came out, the critical volume hypothesis, and it came about initially with, they were studying newts in a laboratory, and what they showed in several animal species is that if you anesthetized them, and then you kept the anesthetic partial pressure the same, but you doubled or tripled the atmospheric pressure, is the animals in the same dose of anesthetic woke up. And so the idea was that potentially that the anesthetics were weakening the neuronal cell membranes, and the animals were then getting into the state of anesthesia, and the pressure pushed the membranes back together, and those nerves worked, and the animals woke up. And, but this ran into a whole lot of problems, partly because different animals needed different pressures to do that. And that was difficult to explain because all of our cells are more or less the same. And then also that when they started looking at the effects of aging and temperature, if you just get a temperature of 2 or 3 degree rise of your temperature when you have an infection, is that you actually get more loosening with aging and with temperature of the cell membrane than you do with anesthetic drugs. And so you don't not anesthetize when you have a temperature of 38 or 39. And so this has really fallen out of favor completely. The areas we're currently looking at are a whole bunch of receptors, and these are largely protein receptors. They're transmembrane protein receptors. So this is the cell membrane. They're typically transmembrane receptors. This one is the GABA one, which is probably a hugely important one, the GABA A receptor, and it has a chloride channel down the middle. But the other things that people are looking at is, so if these receptors are important, which area of the brain are they working in is the next question. So it's not just about which receptor, but actually where are these receptors placed. And more importantly, it might not be a discrete area. It might actually be a bigger system kind of thing that we need to be thinking about. So I'll look through these quickly. In terms of the receptors, this is the groups of receptors at the top that people have been targeting. So there are lots of receptors, and this is the agents that we're using here. These are almost all of them here. So this is the current agents we're using. And there's a state of anesthesia that this patient is in down here. So no matter what agent we use, the anesthesia looks pretty much the same. And yet, whichever agent we picked, the receptor site that it's working at is probably completely different, producing seemingly the same state of anesthesia. And if you take the NMDA antagonists, this is the NMDA group here, and ketamine is sort of the archetypal one of those. If you look to see, it's a potent action at the serotonin or 5-HT3 receptor as well, and nitrous oxide on the bottom here. There's absolutely no effect there. And then if you look at the effects here, they're also different. So these things are acting in very different ways to produce the same type of effect. If you look at the discrete areas that they're working in, the thalamus is the area of a lot of excitement at the moment. It's a very consistent effect site. So that's the thalamus there. And you can see the effect of the anesthetic here, slowing it down, the anesthetic on the left, of 0.25% sevoflurane. So all of the anesthetics seem to decrease its metabolism except ketamine, which falls into a different group of anesthetics, so that's quite interesting. And then at just a tenth of the dose of sevoflurane, at 1/10 of the MAC, you get 23% reduction in the metabolic requirements of that area. And there's a sense that potentially the thalamus is a switch that might be turning off the connection to the rest of the brain, and it might be an important area for the site of anesthetic action. The hippocampus and the mesopontine tegmental anesthesia area are two interesting areas as well. The hippocampus is important for memory, and the hippocampus is an interesting organ. It's hippocampus, I think, means sea monster or seahorse in Greek. But it has its own pacemaker function. So 7 times a second, like your heart has its own endogenous pacemaker, the hippocampus has the same, 7 times a second. If you disrupt that, whether it's by drugs or by trauma or electrically, you then destroy memory and you induce a state of altered consciousness. And this is another area that people are thinking might be really important. And those changes, and anesthetic-wise, you can slow down or alter the hippocampic theta rhythm by anesthetic agents that are completely different structurally. So the mesopontine tegmental anesthesia area, I think, is a fascinating area. So a guy called Devore Marshall looked at it in rats. So this is the human pons, where it sits underneath your brain here. So at the top of the medulla, at the top of the spinal cord, and the midbrain here. Your pons is sitting here. I did this just so you could see that. And so this is this kind of area of your brainstem. And what Devore Marshall did is that he had a bunch of rats that he could put in highly selective catheters into an area of the tegmentum of the pons, which he just dreamt up, the mesopontine tegmental anesthesia area. And he injected barbiturates there, and the animals appeared to be anesthetized, and the electroencephalogram suggested that they met the criteria of anesthesia. So he thought, that's interesting. But he was a good scientist. Instead of thinking, I found the site of anesthetic action, he thought, let's go a step further. So then he took the mesopontine tegmental anesthesia area out of those rats. He cut it out. And the rats were then completely normal rats. So they behaved like normal rats, except if you put barbiturates there now, they were resistant to barbiturates. So his conclusion is that that was probably on a pathway between an important area involved in anesthesia and somewhere else, and somehow he was blocking that. But it's interesting work that you think that you might have found the right thing, and yet it's not the site of anesthetic action. And that just shows how difficult it's going to be to find this. So then if we step back and look at a bigger thing, is it a bigger network thing that we need to think about rather than trying to find a particular molecule at a particular discrete site? And there's an idea that there's a wet blanket hypothesis that if you just slow down, a lot of our agents tend to suppress the central nervous system or just relax it, like the GABA receptors that propofol is so important at acting it. And if you just slow that down, is that you get to a point where the whole network just doesn't work anymore and the patient is then in a state of anesthesia. But it's difficult to work out whether it could just be that everything falls apart or that when you slow things down, that there's one critical area, which might be the neurological correlative consciousness or an anesthetic area, that when that part gets to that thing, that then you induce that state. So it might not be that it's a whole system thing. The wet blanket hypothesis is going to be difficult to work out because there may be that when you're slowing things down, it's actually a discrete area that's going to be responsible. And so it's going to be difficult. And then there's another idea that because sleep is initiated in a forebrain nucleus, that maybe anesthesia somehow is also going to be shown to be initiated there as well, and we don't know that. This is some other fascinating work which just confuses things as well. So it's in goats because goats are special beasts. They don't have, we all have carotid arteries and vertebral arteries taking blood to our brain. Goats have I don't know this, but they have a very poor vertebral arteries, and you could easily just tie them off, and then you just have carotid arteries going to the brain. So what this guy Antognini did is that he put the brains of these goats onto a cardiopulmonary bypass machine, and then he could give the brains anesthetic, and the rest of the body didn't have anesthetic. And you could then study the whole body effect in normal animals, and then the separate brain effects in different animals. He came up with some interesting work. So what he found is that if you have the intact animal, you need 1.3% isoflurane to get to your MAC, your half the animal's not responding to the painful stimulus. But if you separated the brain off and the rest of the body was not, you needed 3%. So basically what that means is that probably when the whole body is working is that a lot of the isoflurane effect that you're measuring in your MAC is actually at the spinal cord level. And to block that just at a brain level, you need twice as much. But then he went on, and these animals were suspended in slings with their brains on a cardiopulmonary bypass machine, and then he turned up the concentration of isoflurane. And once he was getting close to 10 MAC, what he started to see was these animals started to run. They would run. And there was a sense that and then the whole animals, that was not possible to see. You didn't see that. In whole animals, they were completely still. And so there was a sense at higher concentrations, you were potentially activating the brain and causing it to develop these running motions. So it's really it introduces the whole idea that potentially activation of the CNS is what causes, or the central nervous system, is what causes the state of anesthesia. There's a potential for that. And then back to Jamie Slayer. So I think this is the second last idea I'm going to share with you, is that he's suggesting that we need to think of something also at a big kind of system level. And it's something that we see all the time. This is a patient I took a photograph of earlier this week in our theatres at Somerset Hospital, having some laparoscopic procedure. And they're happily anaesthetized here. And then at the end, the surgeons have finished and they've left the theatre. And we're left with a patient here who we've blown off all the vapor, and we're expecting him to wake up. We reversed his muscle relaxant, and we expect him to wake up. And we see this all the time. But Jamie Slayer was thinking a bit differently when he saw this. And what we see on the end-tidal anesthetic agent is that we're running at about 2.2% isoflurane, and that's normally when you expect them to wake up from this. And we often prod them, and nothing happens, and you suck down their throats, and nothing happens. And then moments later, it's still 0.2, suck down their throat, they cough, they breathe, they're uncomfortable with the tube. You pull the tube out, put them in the bed. You can ask them, do you have any pain? They tell you they haven't got any pain. This has hardly changed at all. We know that the concentration, we can see how fast this goes out. We can see that there's hardly any difference. And yet there's this massive change in the patient because he was unresponsive moments ago. And now the same anesthetic concentration, almost, he is responsive and even will answer a question verbally. And so Jamie Slayer is saying we're seeing a state transition, like from water to ice or ice to water. And if we think about it, we're seeing it all the time. But he was just thinking, what is happening at this time? And they've gone on to model this in the laboratory. And what they're seeing here is at the at the time of the change from wakefulness to sleep, they see these massive change in the what they're calling the spectral entropy, from high values to low values here. And when they do this in patients and in models, so on the left here is their experimental patients. What they're seeing here, and on the right is a mathematical modeling of a different form, which I'll come to now. But this is the moment when the patient goes to sleep with the induction of propofol. This is the level of propofol going in, and this is the very moment. And they're expanding the 5 seconds before and the 5 seconds afterwards. And if you look at the EEG in this area here and this area here, you'll see that it's actually quite different. If you just take your mind and you just look at those, they're actually very different. And when they model this, instead of modeling just a surface EEG, they model a whole column of cells, and they don't only look at the excitatory potentials, they look at inhibitory potentials as well. In the same period of time, you can see that in their modeling, there are these massive differences when they look at a whole column of cells, and they see this burst of activity. And this may be more evidence that, in fact, anesthesia is induced by a stimulus, that something turns you on and you go to sleep. And that's the state that we're doing. So it's fascinating work that's coming out at the moment looking at it. There's always got to be a rebel, and that's got to be Stuart Hameroff. So the rest of the guys don't like him, because Stuart Hameroff has spent his whole career looking at what might be accounting for the state of anesthesia and how it might work. And he's linked up with Roger Penrose, the British mathematician, and they have a completely different idea. They think that you don't need nerves at all for the state of consciousness or for the mechanism of anesthetic action, because they have examples of small organisms that definitely don't have nervous systems that you can induce behavioral changes with anesthetics. And so they feel that anesthetics are independent of a synapse and of a nerve. And they believe that it's the microtubules that reside within the cytoplasm of every cell, and they're basically acting as quantum computers, and that's where our consciousness resides, and that you don't need a brain or a nervous system to have consciousness. And if you look at microtubules, if they stained in a cell, you'll have this complex network of microtubules. And they have a very complex mathematical model, which I just can't get my head around, which argues how this can behave as a quantum computer. Now, the rest of the guys, for them, these are like non-believers, because their whole lives are built on discrete areas, on receptors. And now these guys are coming along and saying, guys, you don't even need a nerve. But they can't exclude this, because we don't know what the answer is, both for consciousness and the mechanism of anesthetic action. And so these people still go to the meetings and present their ideas, because somewhere we're going to find an answer, but we don't know where. So people can come up with the most crazy, what seem like the most crazy ideas, because we have to keep all the balls in the park. So to conclude, when anesthetized, we expect consciousness to disappear. But anesthesia undoubtedly induces immobility and a large degree of amnesia. But the extent of its effects on consciousness is much less clear. But to finalize it all, and just to make sure that you don't go home too despondent about what we do, it all remains rather empirical. That's where it came from, and it seems to work. Current evidence of awareness is extremely low, 0.00007%. Satisfaction levels with anesthesia remain extremely high. The ASA closed claims, those are all of the successful legal claims in the United States. They keep an idea of what's happening. Only 2% of those are related to awareness. Anesthetists are getting into trouble for lots of other things, not for patients being aware. And then we remain looking for to explain the state of anesthesia and the mechanisms of anesthetic action. If only we could find the neural correlate of consciousness, and then we could potentially begin to delineate exactly what is the state of consciousness. Thank you.
I know that you said a lot of it was with ether.
Pizza, how did they find that, Pete? Where is Pete?
Was somebody using it and sort of keeled over?
So I know nitrous, they were playing around with. They were playing around with lots of things in the laboratories. I don't know exactly how I can't remember how they discovered ether, but lots of those things were kind of party drugs that they were playing around. They were playing around and experimenting, and it was a stage of great experimentation, and nitrous oxide was like that. They discovered that because people sounded funny when they spoke with it, and so it was really a sort of a funny thing. And then somebody landed up hurting their leg, and they weren't sore, and then they realized, this is quite an interesting thing. And that's how they discovered nitrous as an anesthetic agent. So lots of them were just by experimenting. I don't actually know the origins of ether like that, but it was just discovered empirically. It was a stage. That's how they were talking about spinal anesthesia. I mean, Augustus Beer, he thought of using cocaine because he saw the Indians using it, and then he came up with this idea that if I put it into my back, and he got people, so he came up with the idea, and he got the guys to put it into his back, and he had the first spinal anesthetic, got the first spinal anesthetic headache, post-dural puncture headache with it, but then he became addicted to cocaine thanks to that. But it was a stage of great experimentation. I'm not sure how the ether got in, I'm not sure of that, but basically they were just discovered accidentally. Anwar.
There was a man, I think in the 80s, Ainsley Mears, trying to use hypnosis as an alternative to anesthesia.
Yeah, so I don't know of Ainsley Mears, but certainly people have claimed to be able to do that. I've actually spent an afternoon with a woman in Southampton who claimed to be able to do cesarean sections under hypnosis. But it turned out that, in fact, she wasn't. She was able to assist in childbirth with hypnosis, but in fact, she'd never done an anesthetic for a cesarean section under that. So I think hypnosis works for certain uncomfortable or unpleasant things, but as far as I'm aware, and we had this question earlier in the week, is that for surgical anesthesia, there's no evidence that hypnosis works, although you often hear about it. So I don't know of any evidence that anybody's actually done.
Puncture?
So acupuncture is an interesting thing. So I'm not so sure whether it's been used for anesthesia, but certainly it's as we said earlier in the week, it's potent anti-nausea. So there's a particular area on the wrist that's very useful. And a colleague that I trained with, Andy McIndoe, has done a lot of work in the anesthetic literature. So he's published scientific work showing that actually that particular point is very powerful as an antiemetic. And it's such a safe thing because the side effects are not there, and yet you produce this fantastic effect. So much safer than drugs. Yeah?
Release from this entrance into nothingness. Perfect balm. Rest, dear heart, a while. Impenetrable veil. Easier.
Yeah. So it's interesting. I mean, it's interesting that she talked about dreamless state and those kind of things. And what we're thinking with that isolated forearm technique is there's this suggestion that actually there's a state of dysesthesia that patients under general anesthetic, they actually have vast majority of them, we have no pain, and they actually have lots of blockage of stimulus coming in because of their spinal cord block, but they're actually not unconscious. And that's the problem when you go and give isolated forearm techniques and you ask them things or you ask them afterwards to pull stuff out. They're actually in a completely neutral state and they're pain-free. And as long as you don't disturb them, they're happy. And you might not be making them happy by asking them questions or by going to them afterwards and asking them questions, because actually they had no pain. They were in a nothingness state, which is kind of what she was describing almost. But that's kind of current thinking where we're going to go, is that actually maybe that's the state we're looking for. Yeah. There's several things. They're patient factors. So if you're a young woman, if you have travel sickness, motion sickness, if you've had previous sickness, so you can predict it, that's going to be certain types of surgery. So ear surgery, which we know because of the motion sickness and the vestibular motion sensors. And if you have abdominal surgery, particularly gynecological surgery, there's a lot of serotonin, which seems to be released from the gut, and that's thought to be associated with it. And then there's certain of our anesthetic agents are more emetic than others. So one of the induction agents, etomidate, which you use in quite unstable patients, about 30% of patients will get nausea or vomiting after that. So a lot of it, and that's from a chemical perspective. And if you give lots of opiates, so morphine and all the morphine-like drugs, they can give it. So patients who are at risk or having at-risk surgery, a previous past history, we'll often try and avoid morphine, use epidurals, regional blocks that avoid that to try and minimize that, and then we'd use drugs that target specifically if they're having abdominal surgery, anti-serotonin drugs or 5-HT3 antagonists. So we'd be using that. So they're quite. It's a multifactorial thing. It often depends on your history, and when you get older, you have less nausea and vomiting as a rule. And the older agents were worse. So propofol, that induction agent that we most commonly use, that's actually quite good at, it actually decreases the incidence of nausea if you compare it to all other aspects of anesthetic technique and any other anesthetic agent. So it's actually quite a good antiemetic agent. And then the other thing is that if you have a spinal anesthetic or epidural and you drop your blood pressure, so you're conscious and you drop your blood pressure, people get very nauseous with that. So that's probably often before our blood pressure machines tell us that the blood pressure's down, the patient's feeling dreadful, and they want to vomit. That tells us that basically the brain's probably a little bit ischemic and not having enough blood. We get patients who are anesthetized on the streets with alcohol, and then when they come for surgery, trauma surgery on Friday and Saturday nights, they need less anesthetic agent because they basically done half the job themselves. So it's all the central, any sedative, so that the concentration of drugs that you need is decreased if the patients have had alcohol, if they've had benzodiazepines beforehand, if we've given them morphine, or if they've had morphine in the emergency unit before they come to us. So all of these things sort of add together to make up the state of anesthesia that you require so that you're comfortable and you don't have a recall.
But is
It probably is, I would think. It's very similar. It is basically street anesthesia. Heat. Yeah. Yeah. So that's an interesting thing. So patients who have to take a lot of alcohol, it's not that easy to work out why, but people particularly who their livers are induced because they're having a lot of drugs, and their livers are used to metabolizing a lot of those type of drugs. So they need more anesthetics to keep them asleep. They're at risk of being aware during the anesthetic because they're metabolizing that drug more. But interestingly, there's a thing that we don't understand is that actually they often need more drug to induce the state of anesthesia. And there's no metabolism that's required at that point. We're basically just filling up the blood with a drug, and then they drift off to sleep into the state of anesthesia. And alcohol should make no difference to that, and yet they often need more drug. So we can't explain why that should be, that they actually need more drug to start off the anesthetic. During the anesthetic, we can experience the fact that to maintain that level, they're chewing it up a lot quicker, and so we have to be giving them a lot more. But yeah, so they actually do give us problems. And people who look like they lead a rough life, we have 2 ampules of the drug ready for them when we start. Yes, yeah. So we do. We prescribe brandy routinely in the wards and in the ICUs. In people who declare it, the biggest problem is people who don't want to tell us that they actually have daily alcohol, and then those are the people, unfortunately, who get the DTs. They're too proud to say that. I remember once a registrar said to me, "Is that ordinary brandy?" That because it comes from the pharmacy. I said, "That's very ordinary brandy." Yeah. Okay, great. Hope you enjoyed the course. Thanks.